It is my pleasure to ask the next speaker to the podium. It is Professor Bhattacharya from the UK. He's head of the IVF unit in Aberdeen, Scotland. He's director of the Institute of Applied Health Sciences, and he's also editor-in-chief of Human Reproduction. And he's going to elaborate now on the use or abuse of ICSI. Patty, please.
Thanks for the kind invitation to come and speak to you all. It's a great pleasure. These are my disclosures. I don't think they've got anything to do with my talk today. Given the title of the talk, I thought it would be helpful to remind both myself and the audience what exactly we mean by evidence-based medicine. The reason is the concept has been around for over 20 years now, and it's got to a point where I suspect we each have our own concept of what evidence-based medicine is. It's something that we are comfortable with and that we are passionate about, but each of us tends to practice it in his or her slightly own idiosyncratic style. So again, just to remind ourselves, this is what we are talking about. And what has happened over the years is a degree of maturity in crystallizing how we qualify evidence that we use for clinical practice, how we appraise it, how we grade it. And very interestingly, of course, there is a general view that meta-analyses of randomized controlled trials form the absolute pinnacle of evidence in terms of quality out there. And then you've got the different study designs below. But what I want to remind this audience of is the fact that actually you might start off with a high label of quality of evidence, but the quality rapidly goes down if the study has severe limitations. Similarly, you might start off with observational studies, which are reckoned to have rather low grade of evidence, but they can be bumped up quite rapidly if they show evidence of high quality. I think that degree of complexity isn't immediately obvious to people around the world who've trusted their lot and somewhat worryingly the future of their patients to systematic reviews and, more worryingly, just meta-analyses without thinking things through. So what does that have to do with ICSI? Well, the first thing, I suppose, is to take you on a journey down memory lane, because this was the world pre-ICSI, and these are data from the United Kingdom, from one particular clinic. And what's immediately obvious is in a pre-ICSI era, if you had male factor infertility, your chances of both conception and live birth were pretty awful. And you could see that whether you had one cycle of treatment up to 5 cycles of treatment, the eventual chances of success were so much lower than if you had any other kind of infertility. So that was the moment when ICSI arrived, and you can tell there were a number of previous interventions that were tried, such as SUSI. Those of us who are old enough to remember that will know what that involved. And this was the initial paper that introduced ICSI to the world. And the bottom line is a little bit like the streptomycin study for tuberculosis. The end result was actually everybody got pregnant. And the feeling then was, of course, with ICSI on the scene, it's a little bit like the parachute analogy. As far as male factor infertility was concerned, if your sperm quality was really very poor, you did not need to do a large randomized trial to show that ICSI actually worked. Since then, however, that view has been conflated to a wider population, and suddenly, if you look at these recent data from the United States, you can see that while the use of ICSI has increased in male factor infertility, it's actually shown a more dramatic rise in non-male factor infertility, something that the original intervention wasn't actually created for. And if you now break that down into the different reasons why ICSI was felt to be necessary in non-male factor infertility, you can see the list in front of you. It's for 2 previous failed ART cycles, few oocytes, older female age, etc. And these are issues that I'm going to come back later in the talk, because clearly decision-making has depended on the presence or absence of some of these markers, which are seen as indicative of poor response with IVF. Interestingly, though, while the United Kingdom paralleled this fascination with ICSI in general up to a point in time, more recent data actually are showing that it's plateaued out. So there isn't this exponential rise that we see on the other side of the Atlantic, at least over the last few years. And if you look at the literature, it's absolutely inundated with these kind of papers. And the one thing they all have in common is they compare IVF with ICSI. And the second thing they have in common is the unit of analysis appears to be oocytes. It's always sibling oocytes that are randomized. And that, to me, is surprising because, of course, the outcome we are interested in is the outcome in the woman. It's not the woman who undergoes the intervention, it's individual oocytes. And the outcome is measured in terms of surrogates, such as fertilization, such as failure to fertilize well or failure to fertilize at all. And again, that is very symptomatic of our specialty, where we ask the questions that are easy to answer rather than the questions that should be answered. So this was a relatively recent systematic review and meta-analysis. And what they concluded was the fertilization per retrieved oocyte was slightly better. So if you look at that, slightly favors ICSI. And I say slightly because if you look at the lower limit of the confidence interval, it's 1.02. So that's very close to 1. And if you look at the effect size, it's 0.27. So it could be a 27% improvement. It could literally be a 2% improvement. If you look at failed fertilization, the results appear to be more impressive because what you have here is a relative risk of 8. You can see that. So that sounds like a big effect size. And the lower limit of the confidence interval is 4.4. So again, there's a large relative effect. The question, though, for all of us is what's the absolute effect? And that isn't highlighted in this particular paper. The interesting thing about this particular meta-analysis also is this. It's failed fertilization per cycle. They didn't actually have data on individual women. They had data on cycles, but even cycles is once removed from the unit of randomization, which is actually oocytes. So if you're looking at the laws of how to do an ideal meta-analysis, this would appear to contravene some of those, because what was randomized was one thing, what the outcome is being measured is in another unit here. Okay, we thought we had partially answered the question a while ago, but clearly not. And I'll just take you through this trial, which at the moment, and I know there's another one that's just started, at the moment remains the only large trial so far that actually has randomized women and not sibling oocytes. And you can see that actually you're talking about women who are in their early 30s, because this was 18 years ago. Pretty normal semen characteristics here, quite a long duration of infertility, and you can see different types of infertility, but they're all non-male. And if you look at the fertilization rate per oocyte retrieved, which is this, you can actually see that it's slightly better with IVF rather than with ICSI. If it's per oocyte injected or inseminated, the odds will always favor ICSI because, of course, you're choosing which eggs to inject. And if you look at failed fertilization, there's 5% in the IVF group and 2% in the ICSI group. So for us, the message was that actually ICSI does not guarantee total absence of failed fertilization. And this is the bottom line in terms of clinical pregnancy, which was what this trial reported. It was 33% in IVF, 26% in ICSI, the relative risk 1.27. If anything, the lower limit of the confidence interval, 0.95, is just below 1, suggesting that if perhaps it were a larger trial, maybe, and I'm speculating here, it would tend to favor certainly not ICSI, perhaps could be IVF, but we don't know. So this was the state of knowledge at that point in time in Cochrane. And then a few years later, another small trial came along from Canada, and this was it. And again, they randomized women, and they looked at pregnancy and live birth as an endpoint. That gives you an idea of what sort of characteristics were noted in the baselines of these participating couples. And you can see again that the semen parameters were pretty normal. And what it showed was no difference in clinical pregnancy and live birth rates between the two. And when I added those data onto the previous trials data, this is what we found. Again, the risk ratio 1.18, confidence intervals 0.88 to 1.59, showing no clear advantage of ICSI based on just under 500 women randomized in total. So that's all we have from large randomized trials. But I like this particular paper, which dealt with observational data, because I think observational data have a role, because many people can criticize trials data saying that they represent a proportion of eligible people, but not the generality. So this is from American SART data, and the authors have taken great pains to do propensity score matching when they analyzed the non-male infertility population to try and take it as close to a randomized sample as possible. And this was their overall results, and what they showed was, in terms of live birth rates, there was no difference between conventional IVF and ICSI, with a relative risk of 0.97 and quite tight confidence intervals around it. So that's in the general population, but again, what they did was they matched those who had ICSI with those who had IVF to take out some of the bias caused by clinician preference. Then they broke their analysis into subgroups. So then they looked at couples who had 2 prior failed treatments. And here what they found was actually it favored IVF rather than ICSI. And you can see that the upper limit of the confidence interval is just below 1. And then they looked at advanced maternal age. And again, if anything, it seems to favor IVF rather than ICSI. And when there are fewer oocytes, it's the same trend. It seems to favor IVF rather than ICSI. And I think this was really important because in one fell swoop, it seemed to address some of the deeply held intuitive beliefs in many labs that whenever you're faced with slightly reduced prognostic factors, ICSI is the salvation. ICSI is the panacea, but clearly not supported by these data. And although they're not randomized data, they do give us an idea, and the idea is that ICSI does not offer a huge advantage. So if I summarize that, in terms of our evidence-based approach to the use of ICSI for non-male factor infertility, I think what we've done is we've reduced it to questions which we can answer rather than look at it across the piece in terms of the main question, which gives us more babies? And I suspect there's been a little bit of misuse of the evidence-based label to engage with some of these meta-analyses which are slightly suspect, based on original primary papers which are even more so. And therefore, I would argue before you that the quality of evidence in front of you is not high quality. The little high-quality evidence comes from the randomized trials, but there's more work to be done there because there are only 2. And I think there's a lot of overinterpretation, extrapolation of data. And of course, the very emotive question is, can we offer you something that gives you a higher chance of failed fertilization? And suddenly, that one question swings the whole decision. And it's a little bit about, how people interpret data. And I think all of us have different ways of looking at the very same bits of data in front of us. Sorry, I need help to move on to the next slide, please. That's great. The interesting thing that I'm going to flag up now is also that's been mentioned by the previous speaker, which is the role of the media, and actually here I'm referring to the social media, of how opinions of our consumer group patients actually change the way treatments are interpreted. And I think this has been labeled evidence-based hearsay, and this is a very powerful force now in medicine, where simply the fact that many people are talking up a particular treatment suddenly seems to make it all-powerful, all-conquering. If we look at the use of ICSI in the United States, it's really interesting to see that actually where you have lower levels of ICSI for non-male factor infertility, it is where there is insurance cover for treatment. So in other words, where patients feel less vulnerable, if they feel that they've put all their savings into the treatment, it's a very human, intuitive way of looking at the data and saying they want the maximum that they can get to avoid any chance of a mishap happening. I'm going to conclude by moving on to a slightly different but related area, which is to take up the story from whether you should use ICSI or not. If all other things were equal and people just wanted a more invasive intervention, which gave them the same or slightly improved chances of having a healthy baby and carried no risks whatever, who are we to question that decision? But I think there are some aspects of ICSI which are still unraveling, which we don't understand fully, and perhaps never will. And without trying to be any kind of a scaremonger here, I suspect there is a bit that we don't know about. At the moment, it appears from this very recent systematic review and meta-analysis that ICSI does not appear to cause a higher rate of congenital malformations. But the problem is most of the primary studies reporting congenital malformations are extremely varied, extremely heterogeneous. The definition of malformation changes hugely. If you look at the confidence intervals, they kind of overlap. So I think the bottom line here is there's nothing to be seriously alarmed about. But of course, not all studies will tell you the same thing. So one of the slightly better quality studies was this from South Australia. And what that showed is if you put IVF and ICSI together and lump them together, there is an increased risk of congenital malformations. And this paper is slightly better than the others because it tends to adjust for a few confounding factors. If you look at IVF on its own, it tends to be not particularly worrying. But if you look at ICSI on its own, that risk actually increases to an adjusted odds of 1.55, with the lower limit being 1.24, suggesting at least a 24% increase in the risk of congenital malformations in a study that did adjust for semen quality in the father. And I think that's what sets this study apart from some of the others. Quite interestingly, work done in my own center in Aberdeen has shown something that needs further exploration, which is if you look at this particular gene, you find that the methylation is perturbed, particularly in ICSI and less so in IVF. And you can see that here. So therefore, if I were to summarize all that together, where does that leave us? I think I've shown you the data that shows that ICSI does not lead to higher pregnancy and live birth rates compared to IVF for non-male factor infertility. It does, however, show a lower risk of fertilization failure, although the absolute risks are pretty low, both with IVF and ICSI, and there is no guarantee that fertilization failure will not happen in ICSI. So we found 5% in IVF, 2% in ICSI in a randomized population. ICSI, however, is more invasive and more expensive than IVF, and I think this is one of those things that does tend to play quite a significant role in decision-making, both by clinics as well as by patients. And there is a class of goods known in economics as Veblen goods. And if you can give yourself examples of things like paintings and race horses, where the more expensive a commodity is, the more desirable it becomes. So if you're going to pay a huge amount of money for ART in the first instance, you really want it with all your add-ons in the same way that you might want that extra special bit added on to your extremely expensive car, which you're about to buy. The potential impact of the health of the offspring, again, I genuinely feel needs further exploration. I think we are barely beginning to scratch the surface of any epigenetic changes that might occur. And it may be that everything would be fine, but at the moment, we don't know that. I feel very strongly that the available data is extremely varied and it's interpreted very, very poorly. It's interpreted by us to suit our own personal beliefs and prejudices. And ultimately, there's a loss of confidence in ICSI due to perceived risk of failure, such that it seems to be the first place of refuge for many labs when faced with uncertainty. And of course, this has a downward spiral effect in the lab's own confidence in doing ICSI, and in many countries, and you're aware of who they are, ICSI is used synonymously with IVF because, of course, nobody does IVF anymore, and I suspect many labs have lost all confidence in IVF as a way of fertilizing oocytes with sperm. So it comes down to strong intuitive beliefs, and it comes down to people talking up their intuitive beliefs on very large electronic social media platforms. So therefore, I believe that the potential for abuse in terms of use of ICSI cannot be ruled out. Thank you very much.